Hi everyone, good evening, and thank you for joining our session tonight, the Antenatal Shared Care Obstetrics Update. My name is Lauren Thomas and I'm the CPD Program Officer at CESPHN. Also joining me from CESPHN is Ella Dullard, who is the Population Health and Chronic Disease Program Officer, who also looks after the Antenatal Shared Care Program, and she'll be assisting with our Q&A tonight. We also have Phoebe, Sarah and Gloria online tonight as well as part of our mental health team, who have also been very instrumental with organising the webinar tonight, so thank you. Firstly, I would just like to acknowledge the traditional custodians and sovereign people of the land across which we work, and I also recognise their continuing connection to land, water and community, and pay respect to elders past and present. I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. At the end of the webinar, we'll have an evaluation survey, so that will pop up in your browsers, and we'll also, I'll pop that in the chat. So this will also, we really appreciate your feedback, and this will allow us to give your certificates. Tonight, for any GPs, for all the GPs joining, it's accredited for 1.5 hours of educational activity, and there's also 1 hour reviewing performance activity, which will be sent out tomorrow, which will also give you 2 additional Antenatal Shared Care points. We will submit those activity hours with RSCGP on your behalf. We also have some the remaining Antenatal Shared Care events coming up for the rest of the year. Please register via the QR code just on the screen there. And if you are unsure of your Antenatal Shared Care points, please contact ansc@cesphn.com.au and we can check how many points you are on. I would now like to introduce our first speaker. So we have Sarah Featherbe, who is the Mental Health Engagement Officer here at CESPHN, and she'll be showing you the Mental Health Services Directory. Thank you, Sarah.
Hello. Okay, let me just share my slides with you. Just pull them up to the screen. Okay, good evening, everyone. I'm Sarah Featherbe, and I'm the Mental Health Engagement Officer here at CESPHN. I've been with the PHN for about a year now, or a year tomorrow, but my background spans over a decade across the community and healthcare sectors in various roles. I began my career in capacity building with a community peak body, collaborating with small to medium-sized, highly marginalised NGOs as part of the targeted early intervention reforms. My work focused on helping these organisations enhance their programmes and services, particularly in how they engage with families facing vulnerability. From there, I moved into a child and family portfolio at Wentwest, the Western Sydney PHN, commissioning projects that aim to help build a more integrated service system across the Western Sydney region. One of the most rewarding experiences was the funding of the Thrive at 5 in Doonside project, a collective impact initiative that saw the bringing together of services, preschools, health professionals and government to improve the Australian Development Census results of children across a small Western Sydney geographical area. That experience really showed me the power of collaboration and systems change, and it's why I'm so passionate about the work we're doing here at CESPHN, particularly around prenatal mental health care. Before I begin, I'd like to acknowledge the traditional custodians of the land across the central and eastern Sydney region and pay my respects to elders past, present and emerging. I recognise always their continuing connection to land, waters and community, and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us virtually today. So why collaboration matters? I know this evening I'm talking to the converted here, As GPs, midwives, and other allied health professionals, you see firsthand how complex prenatal mental health can be. When a patient presents with prenatal anxiety or depression, it's rarely in isolation. It's often intertwined with finances, housing, relationships, or perhaps sadly, in some circumstances, family violence. Often no one service can solve all that alone, and that's where collective impact comes in, bringing people together and organisations around shared goals and shared measurement. That's precisely what this directory aims to do. Translate that network thinking into a practical tool that you can use day to day in your practices and work settings. Many of you already would be using the IARDST, which is the Initial Assessment and Referral Decision Support Tool. Bit of a mouthful, I know, to assess risk and guide patients to the right level of care. The directory takes that step further. Once you know the level, it helps you locate a service that delivers it. Clinical services are mapped to the IAR level, but you'll also see psychosocial and crisis support services listed alongside them. Because as we know, mental health care doesn't end at the clinic door. Housing, financial stress, and family safety all play a role in prenatal well-being. Before we go further, I want to show you what the directory looks like and how it works. We wanted a tool that's dynamic, not another static list, something you can use live in your practice to guide referrals. This short video I'm about to play will give you a sense of how quick and intuitive it is to use, and how you can filter by category, IAR level, or wait time and find appropriate services in under a minute. Please note that this is still in the late production stage, so there are still a few changes to be made. So hopefully this will play.
Navigating the wide range of mental health services for your patients or clients can be a challenge. Patients often face long wait times for appointments with psychologists and psychiatrists, and while these clinical supports are often essential, they may not always be the most appropriate, or there may be alternatives to get help for your patients sooner. That's why we've developed the CESPHN Mental Health Services Directory, to enable you to easily navigate the complex mental health landscape and connect your patients with services that meet their specific needs and preferences. Clinical services listed in the directory are mapped to the Initial Assessment and Referral Decision Support Tool, IARDST, levels of care. The IARDST aims to support appropriate referrals, minimizing the burden for health professionals and consumers. In addition, the directory can help you find psychosocial support or crisis services to complement clinical services or provide additional support during the wait time. At CESPHN, we encourage clinicians to use principles of supported decision-making to find services that align with an individual's needs and preferences. The Mental Health Services Directory provides filter options, including age, cultural background, service type, and sexual orientation, to help find the best services for every person. Plus, you can sort your search alphabetically by location or shortest wait time to further curate a shortlist of service options for your patients. Start using the Mental Health Services Directory today and find a range of multidisciplinary support services for your patients. Together, we can bring timely mental health support to those in need.
Thank you. So one of the newest features we've introduced is the wait time traffic light system. And this is a practical addition to the directory. So you will begin to start seeing these color indicators under some of the listings. So red would signify that there's no availability for that service. Referrals are not currently being accepted. Amber is limited availability. Referrals may be accepted, but wait times apply. Green would indicate availability. Referrals can be accepted with minimal or no wait times, or wait times do not apply. What's important to know is that this information is updated directly by providers through automated wait time emails sent directly to them from the directory's developers. So it's in fact reflecting real-time availability. The aim is to make the referral process more efficient. No more ringing around to find out who's taking clients this month. It also helps patients and referrers manage expectations right from the beginning. Now we're going to take a few minutes to explore the directory together. If any of you are able to grab your mobile phone and scan the QR code on this slide, that will take you straight to the directory. I'll give you a few moments. So at the top of the page, you'll see three main tabs. You've got the Clinical Services tab, you've got the Psychosocial and Other Supports tab, and Crisis Services. Down the left-hand side, you can select your IAR DST level of care. You'll then see the number of clinical services listed under that level. There are also other filter options along the left-hand side, things like age group, population group, and type of support. Just note that only clinical services are matched to an IAR level. If you click on the Psychosocials and Other Supports tab, you'll notice there's also a filter by category option underneath. This helps you refine your search even further based on the type of service or support you're looking for your clients or patients. If I give you a few minutes, you will start to see how quickly you can narrow down services that match your patient's needs by utilising the filters options, helping you move from assessment to referral options in just a few clicks. So on this slide, we have some key supports listed in the directory. They're particularly relevant to prenatal and perinatal mental health, including specialist programs, early parenting centres, and counselling services for expectant parents. You'll also find psychosocial services like financial counselling and family support programs listed in the directory. Because as we know, sometimes addressing these practical issues often makes the clinical care more effective. If you'd also like to build confidence with the IAR DST tool, CESPHN runs free interactive training sessions throughout the year. You can email the IAR DST team to register or ask for support embedding the tool and directory into your workflow. You can also scan, another QR code. You can also scan the QR code to find upcoming training dates. So thank you for your time today or this evening and for the work you do in supporting families through their prenatal journeys. Every connection you make and every referral you facilitate helps someone gain access to support sooner. I hope the directory becomes a practical tool you can use confidently in your day-to-day practice. If you have any questions or feedback, please don't hesitate to reach out. I'd love to hear your thoughts after you've had a chance to explore it further. Thank you very much.
Thank you so much, Sarah. That was really, really helpful. Now, if anyone has any questions that they'd like to ask Sarah right away, we have the Q&A function open. We'll give you a couple of minutes to pop some questions there before we move on to our next speaker. There's nothing that's immediately popping up. So we might move on to our next speaker, who is Danielle Pretty. She's the clinical nurse consultant of Safe Start in the Eastern Suburbs Perinatal and Infant Mental Health Clinical Manager and Nurturing Connections Clinical Manager from South East Sydney LHD. Danielle will be presenting on nurturing connections and Safe Start programs. Thank you, Danielle.
Thank you. Hello, everyone. I'll just share my slides as well. Ooh. I've lost the ability to share the sound, unfortunately. I can't click in it, but anyway, let's just go and we won't watch the videos, maybe. Great. Yes, thanks, Ella. And thanks for having me, everyone. As mentioned, I'm Danielle Pretty and I work in Southeast Sydney LHD. And I was asked to come and talk about Nurturing Connections, which is a newish service that we've just started in SESLHD, and also about the Safe Start kind of program across the district. And I'll cover a little bit about Sydney Local Health District as well, because I know some of you work across both of our districts. We've had a couple of acknowledgements as well, so I won't go through it all, but I guess I just wanted to say that I'm actually coming to you from Perth and I'm on the lands of the Wadjuk Noongar people, but I usually live and work on the lands of the Bidjigal people, both very beautiful lands. I guess thought I would start, and I'm sure that all of you are very aware of this, but I guess some of the background to both the Safe Start program and the Nurturing Connections service, which has just opened last year, is kind of the importance of early relationships. And we know that infant and child mental health is understood in the context of their attachment relationships with their caregivers. And we just heard a great way of kind of looking for supports for those caregivers when they're pregnant and in the early perinatal period. And the reason that we want to do this is because that kind of sets kids, infants and children up for, you know, hopefully a better mental health as they go through their life. And I guess we also have an understanding, there's been lots of research and emerging research that we know that even effective treatment of caregiver mental illness or related psychological problems, it's not always sufficient for ensuring optimal child mental health, as there can be kind of ongoing disturbances in the relationship. And that's why services like the Perinatal and Infant Mental Health Service in our district and now Nurturing Connections have kind of come about to try and mediate some of those risks as well and provide families with a little bit more support. This is just the background to Nurturing Connections, which is a Ministry of Health funded program. It's a pilot program operating in SESLHD, in the Mid-North Coast and in Northern Sydney LHD, and it's being researched at the moment. The research is due to finish up mid next year, and so hopefully that will show that it's a helpful program and it will get funded ongoingly and hopefully in other LHDs as well. It was set up to kind of, I guess, be a bit of an extension of the perinatal and infant mental health services, which work with families with complex mental health challenges who have children between 0 and 2 or pregnant and 2. And then Nurturing Connections is able to see families with kids up to 5 years old, where the mental illness is a bit more stable, but it's had some significant impacts on the relationship with their children. I think I haven't successfully shared the sound, but so you could look this video up afterwards, which is just a very delightful short video about child mental health, which kind of speaks to what I've already said anyway. Oh, so the next little bit, I'll just talk a bit about what we do in Nurturing Connections. And as mentioned before, feel free to write some questions in the chat and I can address them afterwards. But I guess in summary, Nurturing Connections is an early intervention program for parent-child relationships, and it's kind of designed with attachment theory, trauma-informed care, and the positive childhood experiences and the ACEs in mind. The objectives of the program and what we're looking at in the research as well are that we're aiming to improve the quality of the child and caregiver relationship, to improve child social, emotional development, and also the adult's caregiving capacity, and to improve the caregiver's mental health and also address some of their other psychosocial needs as well. So the program is designed for, as I mentioned before, for people who have experienced difficulties in their child caregiver relationships and their parenting due to mental ill health, complex trauma, and also other related stresses, such as the things that were mentioned before, and perhaps domestic violence, maybe drug and alcohol concerns, poverty, difficulty accessing care, being from a culturally and linguistically diverse background, etc. The program can work with families for a 6 to 9 month period, and I'll talk a little bit more about what we offer in a tick. So it's made up of a multidisciplinary team. There's some senior perinatal and infant or child mental health clinicians. We've got a perinatal peer support worker, which is really awesome. That's someone with lived experience of perinatal mental distress. And we've got a few actually because they job share. We've got 1 day of consultant psychiatry, and we have a child and family health nurse and also a cross-cultural worker. And the team was set up in collaboration with St. George Family Support Service to make really easy access to addressing some of those psychosocial needs as well. So what we offer is a flexible approach. We can meet families where they're at. There's a range of kind of child giver attachment-based programs, recovery-focused mental health. With the child and family health nurse, there's all that developmental health support for families. And it's a very inclusive program. So we can include primary caregivers of children who are expecting or have a child under 5, and that can be the mum, the dad. If the child's living in foster care and one of those carers has a mental health challenge, that would be appropriate referral as well. Grandparents, whoever the primary caregiver is, and they obviously need to have had a mental health challenge. And the idea is that we're supporting the parent, the caregiver, the infant and child, and whoever else is in the family. And kind of importantly, we're supporting the relationship. I guess some of the interventions that are offered, it's really tailored to what the family kind of want and what they need. But the clinicians are trained in a range of different things. So people are trained in Martimeo, which is a video strengths-based kind of video feedback intervention, circle of security. We've recently been trained in something that's called Parenting Under Pressure, which is a lovely program. DBT, regular mental health support, psychiatry, medication, and then peer support as well, as mentioned. So the referral process is a little bit different from the PIM service, if you've ever referred to PIM. So you can potentially refer directly to the team, and the intake number is there, and then there's an online referral form to fill in. That's some of the criteria up there. There's a few more things, but it was way too long-winded to go on there. But I guess the main referral criteria is that the caregiver has a moderate to severe or complex mental health disorder. It doesn't have to be a diagnosis, but where that disorder has impacted the caregiver-child relationship. And so we welcome phone calls to kind of talk a little bit more about that, because perhaps we might not be the right service, but we're happy to have a conversation about that. And the family also needs to have a couple of psychosocial vulnerabilities. Exclusion criteria is where the caregiver is acutely unwell, and that would need to go through the mental health line, and they'd be seen by the acute care team, perhaps the perinatal and infant mental health team, or inpatient, and then they can be referred to us once their mental health is stable, because they need to have a relatively stable mental health to be able to engage in the program. And if they're already engaged with another like whole of family team or family restoration program, then they're not suitable either, just because it's too many services involved as well. But yes, happy to take calls about things if you had questions. I just thought maybe it would be helpful to talk it through a quick case study, I guess, to show you some of the work that happens. So this was the program started in October last year. So this was one of our early referrals, and we had a mum who was referred by Namaru, which is the parent baby unit at RPA, following a high lethality suicide attempt in the context of auditory command hallucinations. And she'd had her first episode of psychosis in 2023. And when she was referred to us, she was also referred to the acute care team, and she's also linked into the adult mental health service for case management. She also had multiple other vulnerabilities. There was an extensive history of domestic violence from her ex-partner, who was the father of baby. She'd had her own childhood sexual abuse, social isolation, financial hardship. She's on a visa, which means she's not able to access, money or to work or to study. And she was also unwell at the time. And she expressed a lot of difficulty, understandably, feeling connected to her baby due to all of the stresses and her mental health concerns. So we worked with her, and she was linked to one of our mental health clinicians. She saw the child and family health nurse very regularly. They often did joint visits. She had support from the cross-cultural worker and also the peer worker. They kind of tag teamed so that she wasn't too overwhelmed. And everyone worked together and also collaborated and consulted regularly with the adult mental health team. And I guess just thinking about working kind of holistically and flexibly, and with everyone sharing what's going on, we were able to provide containment and support for her to address her mental health concerns, and also really work on the psychosocial concerns with the NGO, so that she could then really focus on keeping her infant in mind. We were able to use everyone's expertise and experience to best meet her needs. And there was lots of advocacy and time to kind of address all of the areas of concern, and also to really highlight her strengths. And I think the whole multidisciplinary team worked together to create a therapeutic relationship, which really demonstrated to this mum what a secure attachment can look and feel like, which then is hopefully going to be excellent for her going forward with her baby and perhaps future children as well. And I didn't mention before, but we do the work kind of wherever suits the family. So it's predominantly home visiting, but people can come into our office as well if that's better. If there's significant domestic violence at home, then that's probably more appropriate. We can meet in the community and help people access community things as well. I just wanted to, I guess, put a quote up. So some of the quotes are from some of the research that's been done. There's qualitative and quantitative research going on. And I think as a team, we feel like we're able to do mental health a little bit differently from other mental health services. And this person fed back, for me, something that's really, really stood out is how kind of flexible and person-centered we've been able to be. Like I felt with each of our individual parents and families, that's just been so amazing to be able to really get an understanding of them and what's going on for them and what they want and need, and then to the best of our ability to be able to meet that, rather than it being something where we're sort of telling people, well, you have to do X, Y, and Z, or this is what we offer, and you need to fit in with that. We've been able to just be, really flexible and responsive to each parent and family. And I do acknowledge that that is a huge luxury in mental health. And the other service that I manage, the perinatal and infant mental health service, we do work flexibly and are able to do some of this, but other services in mental health are really, really stretched. And that makes this kind of work trickier. I'll just skip through. I don't need to go on about them. So just for the sake of time, we're just going to flip now onto one of the other parts of my job. I'm the Safe Start coordinator in SESLHD as well. And I'm imagining that hopefully you have all heard of Safe Start, or you might not have, but Safe Start is the New South Wales Health framework and policy guides to help guide us to think about people that are accessing our maternity services and our child and family health services, and to try and make the links between those services and mental health and drug and alcohol much smoother, and to kind of pick up women early in their pregnancy who might benefit from some extra support and try and, facilitate that. So these 3 documents that you can see on the screen are the 3 different bits of the policy or the guideline. They're really old, and they are being reviewed at the Ministry of Health at the moment. The review has gone on for some time, but actually we had our New South Wales Safe Start meeting last week, and it's almost ready and going to be shared with the districts for feedback really soon. I don't think there's dramatic changes. There's just some tweaks to things. But I guess just an overview of the core principles of Safe Start. And I think this kind of also follows up really nicely from the presentation before about that amazing online system. Because I think when we're screening women early, then it's good, that's a great way of finding what might be the most appropriate service for them, or the most appropriate support. So the core principles of Safe Start are that it's trying to promote continuity of family care throughout pregnancy, postnatal and early childhood periods, where we understand the risk and protective factors in health, and I kind of alluded to some of the risks earlier on. Safe Start also acknowledges the role that parents and family systems have in providing sound foundations, and it's not always up to services and GPs and mental health services to do this, that we can access other things as well. We also know that interventions, when they're undertaken early, can often be more helpful. And if we can be flexible and then respond to family, that's going to be helpful as well. Safe Start also understands that we do need a comprehensive network of resources and services, and it highlights the importance of partnerships for service delivery as well, and thinking about effective communication, collaboration, cooperation between the family and also all of the services that are involved. And I guess when we think about it in the public health sphere, that's, as I mentioned before, that's thinking about midwifery, child and family health, mental health and drug health services. But then we liaise with NGOs, with GPs, and with all of those other services that are happening around the public health service as well. That's another video, but unfortunately I can't share it. It's a lovely video, and it's kind of a good explanation of what Safe Start kind of is for families to watch. And the information is on that other sheet there, which is helpful to have up in waiting rooms and things. So Safe Start is those policies that you saw before, and it guides what we do. So when women come in to the public health service for maternity, on their first appointment, what might be the first or second, everyone gets screened for psychosocial risk, and also with the Edinburgh Depression Scale. So thinking about mental health stuff as well. And we screen because we know that 1 in 5 women experience mental health concerns in the first 12 months after a baby is born. And some of those things can be a little bit predictable. So it's good to have an understanding of what's been going on for that woman for the last few years and even back into her childhood. We know that becoming a parent can bring up past experiences which might have been traumatic, and we also understand that they can have a serious impact on the mother-baby relationship and as well as the rest of the family. And we also screen because we know too that emotional health and well-being is just as important for physical health. And so it is part of the routine care that we offer in our maternity services and from what I understand, in our GP services that are supporting pregnant women as well. So I guess as part of the screening, as you would all know, it's important to kind of explain some of these things as well, so that women have, it's contextualized for why we're asking these questions. So yes, as I mentioned, the policy guides us to screen, and we do the assessments not only in maternity, but also as that family then moves into accessing child and family health services. And so sometimes people are screened who've birthed in a private hospital where they often don't do any screening, and that mum might present at the child and family health service, and they do the same screening that the EPDS and also the psychosocial screening. And women might be picked up there, and then they can also be supported from them. And sorry, I forgot to mention too, also part of it is the domestic violence routine screen as well. And that gets screened multiple times through the pregnancy and the early postpartum period as well. And if there are risk factors identified, then women are kind of flagged, and then they're brought to what's called a Safe Start MCD. And at the Royal Hospital for Women, we have the antenatal MCD, and then there's a postnatal one with Child and Family Health on a separate day. But at Sutherland and St George, they have them all together, the antenatal and postnatal. And in Sydney Local Health District, yes, they have one kind of in the RPA area and one at the Canterbury Hospital area as well. Sorry, I'm just thinking if I wanted to say anything about that. I guess, yes, the other thing which I think you would all understand as well and appreciate is that sometimes it's not possible to screen at that exact time because there might be the partner there or something else is going on and taking kind of priority. And so the screening is not set in stone. It can be done, fluidly and kind of at any stage, or it can be reassessed at any stage across the perinatal period. And the child and family can be re-referred to the Safe Start MCD at any time in that period. I've possibly covered this. I guess, yeah, sorry. I think the first talk kind of touched on this as well. If there's some psychosocial risk factors, then there are also lots of services that might be able to support with those things as well, not just the mental health service. This is a very busy slide. My partner almost had a heart attack. He's a graphic designer when I put this on the slide, saying that's way too much information. But this is just cut and pasted from the Safe Start, one of the policy documents. And I guess it's just to show you what kind of happens. And women are divided into these levels of care, like 1, 2, and 3. And 1 is where there's like not really any risk factors, just people, plodding along okay. And they are able to access the universal kind of service. Level 2, there are some identified risk factors. And so they might need, to access social work or a couple of other services. And then level 3 is where, perhaps then they might be meeting the criteria for perinatal and infant mental health service and things like a bit more at the pointy end of things. I just thought maybe it's helpful to talk about what happens at the Safe Start. It's meant to say MCD up the top there. It is a multidisciplinary discussion of complex families. And so involved usually is, or always actually, is maternity, child and family health nursing, mental health, drug and alcohol, and the women's and infant social work team. And then other people can be brought in. So sometimes there might be Aboriginal mental health might come, or the Aboriginal midwives might come along. And I know other districts, we don't do this in SESLHD, but other districts sometimes have private practitioners or NGOs come along as well. And I guess Safe Start is a process, not a program. So the MCD, someone presents talks a bit about the family and their concerns or what the issues are. And then it's an opportunity for support and advice drawing from everyone that's in the room. There is a focus on strengths for the family and protective factors. And there is also development of coordinated care plans, which address the risks, but also build on the strengths. And there's also, it's a really easy way to access all of those referral pathways as well. So people can be referred directly through the MCD to different services that are also present there. And the main worker with the particular family will write up a plan for the birth as well. And that gets discussed with everyone and people can feed into that. And from the Safe Start meeting, then people liaise with external services as well to feedback about what the plan is. You probably know both of these things, but I guess I just, yes, remind you about if you are doing or if and when you're doing psychosocial screening and Edinburgh depression and mental health screening, you know, the mental health access line is a very excellent place to call if you've got worries about acute mental health risk and concerns, and also a way that you can refer into the perinatal and infant mental health services as well. That has to come through the statewide mental health access line. And I think really helpful for GPs is Mother Safe. And I'm presuming that you have hopefully heard of it and called it, but they are like fonts of all knowledge of medications and like multiple other things in pregnancy and when women are breastfeeding. And that's a really good place to call if you're querying, if you're seeing someone who's been on an antidepressant, say, and you're wondering whether that is safe to continue in pregnancy or if it's better to stop, please call Mother Safe. We do have a number of women that access our perinatal and infant mental health service who've had their medications ceased suddenly because they're pregnant. Maybe, you know, they've chosen to do that, or maybe that's the GP suggestion. And that's not always the best thing for people. Sometimes it's much safer to stay on a medication and weigh up the kind of risks, and Mother Safe can help nut all of that stuff out. And then I also just wanted to say that I am very available to chat. You know, if you do have questions about women that you're seeing and wondering, you know, whether they'd meet criteria for PIMS or for nurturing connections, obviously, then please give me a call. Or if they perhaps haven't disclosed things at the hospital and you're wondering whether that's something that should be shared with the service, then we can talk about those things as well. So I am the Safe Start coordinator for all of SESLHD, and Alison Tutt, she's not called the Safe Start coordinator, she's called the perinatal coordinator, but she functions in quite a similar way, and she is the person in Sydney Local Health District, and she's happy to take calls or emails as well. That's all of my slides. Thank you.
Thank you so much, Danielle. That was really insightful. We've just got a little bit of time for some Q&As now. We've got one here that's asking, what is the eligibility criteria for Safe Start? And then another question, age of child, question mark.
Oh, yes. So Safe Start, I guess, as I said, it's a it's a like a policy thing, not a program. So to be able to be discussed at the Safe Start MCD, which I guess is what kind of Safe Start is, it's during pregnancy or up until the child is 2. But I think if you had queries about someone that was slightly older than that, I'm happy for you to give me a call and we can think about what the best service pathway would be.
Thank you. And then there's another question here that asks, is Abilify safe in pregnancy? I'm aware that is safe. Is that maybe a medication?
Yes, that is a medication. And yes, that's a good thing to call Mother Safe about as well, because it kind of is dependent on what else is going on for the person. So yes, I call Mother Safe and have a chat to them.
Lovely. Awesome. So I think Gloria has answered one of the other questions. So that's all we have at the moment. Thank you so much, Danielle. Really appreciate your time.
No worries. Thank you for having me.
And our last speaker is Dr. Kavita Seth, who's a psychiatrist at Dokotela, who will be presenting on perinatal mental health. Thank you, Dr. Seth.
Thank you. Okay, let me share my slide. I'm hoping everyone can see this. Ella?
Yep.
Yes.
Okay, amazing. Okay, so thank you everyone for joining in today. I'll be talking about mental health care in perinatal period, and I'll send you the link at the end of the session today. But it's mainly from the Australian Clinical Practice Guideline that was released a couple of years ago. And it's really useful, and it does talk about medications there. I will talk about medications towards the end of my session as well. So today I know we have only half an hour, so I'd like to really briefly talk about screening for depression, anxiety, psychosis, and PTSD, assess any other factors that can affect the mom's mental health, and assess perinatal mental health even in fathers. I will talk about the prevalence of mental health in non-birthing parents as well, and assess mother-infant interactions and safety of the infant, supporting emotional health and well-being, prevention and treatment, postnatal care and support, and then about women with severe mental health illness, and I'll talk about pharmacological treatment, and also women who do not respond to pharmacological treatment. So as all of us know about the Edinburgh postnatal depression scale, this can be done even antenatally, and I do urge us in our practice to keep it handy and to have it there. You could even ask reception, while the mom is waiting, the pregnant mother is waiting for her appointment. They could like really quickly fill it out, and well, when she comes into your appointment, I know you all are very busy. You can have it there, in front of you, and quickly do a score, or reception could just help, count the scoring for you. And a total score of 13 or more is considered a concern, and it can sort of err on depression. But then again, there's a lot going on for during pregnancy, and psychosocial stresses are there, or maybe she's had a bad news, or just had a rough day. So I usually do advise that we could see them again in the next 2 to 4 weeks and repeat the score. And if it's still higher, 13 and more, then you can talk to your patient and assess if there's anything else going on, or whether it is time to talk about maybe depression that is causing her to feel that way. And also in the Edinburgh scale, questions 3, 4, and 5 which is it does concentrate more on the anxiety. So even if like they may not score more than 13, but certain scores are high, like threes, then just have a think about, what is going on there. And for questions 1, 2, 3, and 10, they are more about the self-harm and also uh, severe depression, and maybe assess whether the mom, and if it's a postnatal, whether the infant is doing okay, and then maybe refer on to mental health teams if you're worried. So that's the Edinburgh Depression Scale. Now, for non-birthing parents, 1 in 10 fathers, I know that it's not just fathers, but this statistics have shown that at least 10% do experience depression in the first trimester and even in the first year of postpartum. And it could be sudden neglect, or not purposefully, but the mother is spending more time with the infant in the first year and doesn't have enough of time or support for the non-birthing parent. And 1 in 6 can actually experience anxiety in the prenatal period, and 1 in 5 um, can also experience in the postnatal period. Fathers may experience PTSD following birth, and half of the fathers may be even unaware that they're experiencing anxiety and depression, and the lack of awareness means that they are less likely to see their GP or even ask for help. So I know that this whole talk is about perinatal mental health, but please don't forget the non-birthing parents as well, who most of the time they are there, struggling silently, while a lot of attention is focused on the birthing parent. So during your clinic, it would be good to assess, mother-infant interaction, and part of the mother-infant interaction, you could ask about how the mother ask the mother how the baby's daily routine is, or you can see whether the mother is empathic to the baby crying or being uncomfortable in your clinic, whether they are able to talk enjoyably about their baby. They are interacting, talking to the baby at the same time, and whether the baby is, it's a bit hard to tell whether they are totally they are uncomfortable or unhappy. But these are things that you can see some subtle signs, or even ask the mother. Sometimes moms book appointments in the first year of the baby's life in your clinic, asking you every single thing under the sun. If it's a tiny temperature, or if there is a little bit of rash. I'm sure you've experienced that in your busy clinic, whether they're excessively worried about the baby, whether the mom can cope with the baby's distress, are her responses consistent to the baby's cues, is she protective of the baby, and whether she keeps the baby clean and healthy. And I was talking about psychosocial factors that can affect, the mother's mood. Um, Maybe, yeah, and most of y'all will know your patients over the years, and they have now, they are now pregnant and they've had their baby, whether a past history of unresolved trauma, or any pregnancy loss, or stillbirths, if this pregnancy is was unplanned or unwanted, and the mom still has reservations about the pregnancy or even the baby, um, whether the mom experienced birth trauma, um, if the mom has responsibility for the infant care during the first week of life, or if there's anyone else involved in the baby's care. and the availability of herself emotionally for the baby. These are things that you could assess very quickly in your GP setting, especially if you know the mom for a very long time prior to even the pregnancy. And as for the infant, you would check, whether there's the baby is having, has reached the normal developmental milestones. Are they growing well? Do they have feeding difficulties or any other health concerns? Um, you will start to get a bit worried in your practice if you see that the babies, having gaze avoidance or flat affect, or they're not really vocalizing, or they're not reaching their developmental milestones, or they are a bit, if mom says they have been unsettled in feeding or sleeping, or difficulty to be consoled, or irritable, and even some separation anxiety, which is, of course, age dependent. Other factors could be, when you assess the maternal mental health, would be their past history of mental health diagnosis, including personality disorders or mood disorder, psychosis, previous suicidal ideation, or having risk of suicidal or self-harm at the moment. Any negative symptoms? Are they having a flat effect themselves when they see you? Are they on any medication, and is that causing any side effects? Are they using substances or dangerous, risky behaviors? These are things that will be cause of concern and red flags. But the good protective factors in mother-infant interaction would be mom is actually responsive and sensitive to the baby. They have a good support system. They are able to monitor the baby's welfare, and they are able to cope flexibly with the baby's routine. And they are thoughtful about what's going on with the baby. So these are all protective factors. Now, the guideline do recommend that at every visit, take it as a good opportunity to ask about the mom's welfare, emotional well-being, and whether there's any stresses going on. You can do the Edinburgh depression scale, and assess whether they are having ongoing depression. You could even repeat it after you start medication and see if it's getting better. Whether you would want to refer on to a local mental health team, or get specialist support at that time. So every opportunity is good, and if at all you can, even inquire the well-being of the non-birthing parent as well. um, these are all opportunities to assess the family unit if you can. I know you all are busy, but in your GP practice, so every opportunity does help. And for planning the care, if the mom comes to you early on in her pregnancy, or even a preconception kind of appointment, and they have severe mental illness, it's perfect if it when it's planned. But most of the time, they do come unplanned and mid pregnancy. Even then, it'll be great to see if they have especially history of schizophrenia, bipolar disorder, borderline personality disorder. It'd be great to have a multidisciplinary team approach to look after the mom during their perinatal period, and also postnatal. It is very hard, I know, with mental health teams being overstretched. But if you could put in a referral early on, or refer her to uh, the private clinic, some like Dokotela, early in the pregnancy care. The mom can see us via telehealth, or if you feel that the mom would need more support face to face in the local community, local mental health team would be good. And it's good to put in an early referral, and even if mom is doing well, that's great. But at least the referral is there. Should they decompensate during the pregnancy, and it is important that we stay trained as well in looking after patients with complex mental health, physical health needs in pregnant women. So I'm really grateful that you all are here today to hear the talks. So when it comes to pharmacological treatment, okay, um, when you talk to perinatal specialists, at the end of the day, the mom's health is very important. So even if it comes to a point where you worry about the teratogenicity uh, of pharmacological treatments, if the mom definitely needs it at that point, then it is important to start the medication, because if mom's mental health is not well, inevitably baby's mental health will not be well as well. So it's good to talk to Mother Safe at that point, or involve a specialist at that point. But I'll give you guys some pointers today. But if at all you need to step up the dose or try something else, because the safer ones has failed, I think it's important that you feel comfortable to do it, and start slow, and refer on to places like Dokotela or the local mental health team. So try and have the non-birthing parent there. I mean, if there's no DV issues or anything like that, domestic violence issues, or if the mom has a good support person during her pregnancy, it's good to have both in your room and discuss the risk of mental health, and the benefits and risk of treatment in pregnancy, and how you would follow up while waiting for specialist involvement. Talk about the likely benefits of each treatment, considering how severe the mental condition is. See in your notes, or if you're in a big GP clinic, see the notes of previous GPs that have seen the patient, and what has worked and what hasn't worked for the patient. Do a background risk of harm to herself or the baby, and at that point assess whether the mom needs to go to hospital to initiate treatment, or whether that hospital admission is not imminent, and whether you can start. Assess the possibility of the onset of any relapse of symptoms, and more so in the first few weeks of childbirth. That's when they don't have enough of sleep, and like the bipolar patients, and that's when they start becoming unwell, manic, or very depressed. And try and book regular appointments to assess this, and where you feel that instigate, you need to start some form of treatment, please do so. And if it makes you feel more comfortable, have Mother Safe on the line. But to be honest, if there's been past failed safe treatment that was tried on the mother, then, and if you need to step it up, then please do so, and while waiting for the specialist. Or you can call the mental health team for support, or you can send the mother to the emergency department if at all her mental health is quite risky, unwell. But if you start treatment, just monitor the response, and and if you need to change treatment, do understand that there'll be a period of time where there is a tapering off of a previous medication and a starting of a new medication. So the mother may be on a subtherapeutic level of something, and therefore the symptoms may be a bit more pronounced during that time. And also monitor especially our atypical medication, or certain classes of antidepressants can cause weight gain, and it leads to gestational diabetes for the pregnant mother. So these are things, some pointers when you are assessing treatment for the mother. Um, and when you have decided, I will talk about the types of medication in a bit, but just some guidelines first. When you have decided that you want to start pharmacological treatment, and you start it, you would preferably want to seek further advice from the specialist, and you will of course if at all it's a pregnant mother sitting in front of you with no previous mental health history but quite depressed at the time, never tried any medication before, you would go for the safest, lowest risk profile. But many a times we're in front of the patient is in front of us and they've tried various treatments in the past and they are quite depressed or quite anxious in front of you, and it's time to try something else. So you would, whatever that you try, use the lowest effective dose and step up gradually and use a single drug if possible. And please understand, that as the pregnancy goes on, mom is a bit heavier, that you might need to increase the dose even. So think about these things when you're seeing the mom while waiting for specialists to get involved. And there's always our Dokotela chat group as well for our GPs, and you can post something then, and one of us almost always respond in record time. So if you ever get stuck, please use the GP chat group for Dokotela. um just something about the early postnatal period is a time where it's very emotional for most women, particularly, I mean, planned or unplanned, but more so when it's unplanned, and they are not in a stable relationship maybe, and suddenly both of them are becoming parents, the mother and the non-birthing parent that never thought the relationship would be that serious, have now are going to be parents. So it's quite emotional for most women, also for non-birthing parent. And it'll be it's a good opportunity to talk about where they are at in terms of their relationship, how accepting are them of the pregnancy, whether they want to continue with the pregnancy or they're still thinking about termination. Do remind them, if the mom brings up about termination, do remind them the cutoff for the number of weeks, and where they would have to decide on, and do support them, refer them on to other services that can support them during that period. And early intervention is good. So if they are starting to feel a bit depressed or anxious, you would see them again and repeat the scales, or start them on something small and see them again in terms of medication, and see how they are traveling. um, if there is postpartum psychosis, most likely is due to lack of sleep and sometimes lots of coffee, trying to keep awake for the baby, and prior history of psychosis or mental health diagnosis. Then it is important to address that very quickly, and try and address also why the baby is not settling, and whether the mom can be referred on to other services for the baby. Women with severe mental illness, they do find the bond quite challenging, and the early period quite stressful, especially if they don't have much supports. It'll be useful to refer them on to services there, and see if we can engage a significant other or family member or a very good friend that can check on them as well. Women with EUPD, borderline personality disorder, they inherently will be most likely having difficulties, and it'll be good to in to assess them and refer them on to services, and also try and follow them up if they do have substance use issues and all. child protection is there, um, or the family child services, they can be involved early on. They are there to support the mom and the non-birthing fathers. I know they do carry such a stigmatizing name, but they try their best. I have worked with a lot of docs, and now it's called facts. I do try, and I've worked with them over the years, and the last resort is to take the infant away, the baby away. But until then, they do try their very best to keep the family unit together. Or if they have to, have the baby looked after by someone else, is almost always with a they'll try and find a close family member to take care of. So involving them early on is good, because they can refer on, or they can advocate on your behalf, on the GP's behalf, for more services to be involved, mental health wise. And early, we always know that early diagnosis, early intervention results in a better outcome for everyone. So women with severe mental illness, when you are planning care, so when they go to the hospital, they have delivered the baby, do tell them to book in with yourself quite early on, to talk about how they're going to, go about looking after their baby and themselves. And if they have the non-birthing parent has got severe mental illness at themselves as well. Most often, they would already have a case manager in the mental health team, or they have been known to a mental health team. So involving them early on, home visits and things like that will be very good. And if the mother requires a hospital admission, because not coping, it would be good to try and find a mother baby unit. I know these resources are very scarce. It is really hard to get into one, especially if the mom doesn't have private health cover and all. But these are just guidelines. It's just to help us in our day-to-day practice. We can only advocate at the end of the day, for something ideal like this. Okay, let's talk about medication. We all know that SSRIs are the first line medication to use for depression and anxiety. So we try to use sertraline, citalopram, even fluoxetine if you have to. It's longer acting, but sertraline, citalopram are usually the first few lines of SSRIs. I know a lot of obstetricians do use desvenlafaxine as well, 50 milligrams, a lower dose if SSRIs do not work for the mother. But in your practice, even if you start on something, do refer quickly to either the local mental health team or Dokotela, and they can take over the prescribing. If the mom has got, is quite sensitive to the initiation of medication, then a tiny dose of benzodiazepine is okay within a week or two, just to alleviate the anxiety. We need to understand that if the mom is constantly depressed and anxious, the antenatal period for the fetus is not going to be great either. So you'd want to use like a low dose of medication to alleviate them from their struggles. The use of Z drugs like zolpidem or zopiclone are not really good. The guidelines do encourage doxylamine if you need to try a pregnant mother for severe insomnia. And also, you can use antipsychotics. While I was working as a perinatal registrar, I used a lot of Seroquel and olanzapine as first line, because you want some kind of sedatives as well. I know someone asked about Abilify. It's a class C medication, it can be used, but we know that Abilify does increase restlessness. Then you'll have to give something like a benzodiazepine for the restlessness. So, if you want to try medication for psychosis, or anxiety or lack of sleep, I have used a low dose of quetiapine for the pregnant mother while waiting for a specialist to be involved. So I hope that alleviates the medication for antidepressants and antipsychotics. And a bit of a low dose of benzodiazepine. We don't want to go beyond couple of weeks, but hopefully you'll be able to get an urgent appointment with Dokotela or the local mental health team by then. Given the teratogenicity of the anticonvulsants, especially valproate, we try not to start them on these things. Even with bipolar disorder patients, we usually go with olanzapine, or quetiapine. If the mother has been on lithium in the past, I always encourage GPs, even myself, when I see a young woman being treated with some high-powered medications, it may not even be mental health. It could be, physical health, or epilepsy or a cardiac problem. I always try and get a specialist opinion for the childbearing mother at the same time. So, whenever you have someone that's coming to you in their 20s, do have like some kind of like a light bulb or an alert in your mind that you'd want to send them for just to talk about medications, should they become pregnant. And it's really useful because the more and more you do these things for just a prenatal checkup, even when the young lady is in front of you and they say, I don't want to have kids. I'm not even thinking about it now. I usually tell them that, it's worthwhile just having some opinion in their file so that, when it happens, we're not rushing. And also, the more and more you hear from a cardiologist about some safer medication for pregnancy, or neurologist for epilepsy, or mood disorder from a psychiatrist, you will actually form your own experience with these medications. It come as second nature. Okay, so once you have this, when the patient has decided, okay, so you need something a bit more than that, then lamotrigine has been starting to be a bit more favorable, but you do need some close monitoring. I know with lamotrigine, a lot of obstetricians like to give a higher dose of folic acid, but talk to Mother Safe, and if you need to start on lamotrigine, then that is possible. Lithium is also possible. It is important to know that it is good to check the blood levels quite frequently. I would actually say monthly. And towards the end, towards the later part, the third trimester, you actually might have to increase the lithium because of the increase in weight gain and fluid volume in the mother. So just be mindful of that. And on delivery, we are hoping in the hospital that they will actually alter the lithium dose then to prevent lithium toxicity post delivery. So if the patient does have mood disorder and unable to stop medications, have been on it for a very long time, then I think it's important to involve a specialist early on, for just some advice should they become pregnant. Now, I hope I've alleviated the concern about antidepressants, anti-anxiety, antipsychotics, and mood disorder. Now, if at all the mother is not doing well, despite the treatment, it is important to make sure at that point that the relevant specialists are involved, and you do want to make sure that they are reviewing the patient regularly. But just some pointers, ECT is quite safe, and it's used as a first line for depression or mania for pregnant mothers and postpartum mothers. It is very effective. Um, the response is almost immediately, and it is something that is considered in our mental health space if medication alone is not working. TMS is there. It's starting to have some popularity as well because it's non-invasive, it's Medicare rebatable, and it does not require sedation. So that's something that mothers or postnatal patients can actually think about if medication alone doesn't work. So in summary, you'd like to see the patient quite regularly, your mental health patients. You provide psychoeducation wherever possible, involve their significant other. If you can, you would do a preconception planning, but sometimes or most of the time, that's not the case. If the mother has come to you quite progressed in their pregnancy, then try and liaise with other health professionals to involve in their care. Where medication is important to be initiated, discuss the risk and benefits with the mother and initiate. But you want to be on, try single dose, lower dosage, increase gradually, and review frequently. Discuss the risk of relapse and early warning signs. I love that term. I talk to my patients about early warning signs in their relapse. So it's like, Sarah, if your patient, you remember that when you didn't have sleep for more than 3 days, you start becoming a bit manic, hypomanic, you start, increase in speech or get a bit irritable, short with others. These are all early warning signs for your patient, and their significant other can also recognize this when it's happening early, and early intervention leads to better outcome. You plan for breastfeeding as well, and in terms of medication, and by the time hopefully they are involved with a specialist, and you will encourage them because women with mental health have got a lower attendance rates for antenatal care. They are quite chaotic sometimes, and so encourage them to attend their ultrasounds and midwife appointments in the hospital. You'd like to see the baby early on and assess the interaction between mother and baby. Where possible, try and get a mother baby unit if you can. I know it's really hard. Take a team approach. You're not alone, and where possible, like how you guys are today, undertake some training. You're not alone. We are here for you in Dokotela. Like I said, we've got the WhatsApp group, and you can always get in touch with our specialists anytime. But if you feel like the patient needs a more intensive approach, there's always the local mental health team. And if all end fails, the emergency department is there uh, to help you. This is the guidelines that you can read more on. It's really user friendly. Um, I do recommend that you guys um, go through the guidelines. But yeah, hope you guys are happy with the pointers. I'll stop sharing and see if there's any Q&A. Can women on ADHD medication in pregnancy? Yes, okay. Yeah, apologies. Didn't include ADHD. And I am an ADHD specialist. Okay, so ADHD medication, it is fairly okay. I try and I do talk to my patients, and you know what? A lot of them do not continue with ADHD medications during their pregnancy, especially in the first trimester, because by the time they find out that they are pregnant, the heart is already forming in the baby, and the first trimester is the biggest risk when they are on stimulants. So they try and, I try and tell them that, if they can do without, it's the best. But if they can't do without, then the lowest dose, like 5 and 20 or 30 milligram, or a couple of dexamphetamine tablets. But you know what? ADHD medication is such that there's always a specialist initiating. I know we haven't come to a point where GPs are initiating and prescribing, but they already, at this point in time, they already have a specialist that you can ask for further advice. Breastfeeding. So you would try amphetamines for pregnancy if they are very adamant on being on medication despite the risk that you have explained. Um, Ritalin is not good. It's for pregnancy, but Ritalin does not cross the barrier for breastfeeding. So it is a better medication for breastfeeding. So you'd be on a lower dose for breastfeeding. Um, and Dokotela link. Were you talking? So I hope I've explained about the ADHD um, medication for pregnancy and breastfeeding. The Dokotela link. If it's the GP WhatsApp group, then I think we can share that in an email. And if it's the guidelines, Ella, if you can just cut and paste my guideline in the last slide, that would be great.
Absolutely. We've put the Dokotela community of practice in the chat, as well as the guidelines, but
Yeah.
we'll also do it in a follow-up email.
After the first trimester, is dexamphetamine quite safe? It is safer. So things are not really safe in pregnancy. Not many are class A medication. But I do talk to mothers about class, about the fact that it is safer. It's a class B medication. So I do say that low dose. So I have started. The question is, have I started as well? Yes, I have. I do talk about the risk and benefits, and I do a low dose. Some mothers they just stay on their Vyvanse, but a lower dose. If not, then dexamphetamine, 1 or 2 tablets twice a day. Yes. Was there any other questions that you all had? Thank you.
Thank you so much, Dr. Seth. We really appreciate your time, and thank you to all of our speakers who have presented tonight, and to the attendees for participating in the webinar. A reminder to complete this online survey that will pop up in your web browser, and keep a lookout for optional reviewing performance activity that will be emailed to you tomorrow. We look forward to seeing you online again soon. We do actually have just one more question. Sorry, maybe
Yes,
we
about
can.
the clozapine throughout pregnancy, or do they need to be changed onto an alternative antipsychotic? Look, it's a very difficult question to answer, like that, because I have patients that have been on clozapine during their pregnancy. The thing to understand is, the last thing you want is to destabilize the mom. So as we know, clozapine is given for treatment resistant schizophrenia. So changing them to something alternative may not be the answer. So it is important that this is done by a specialist, and for them to stay on their medication until they are reviewed by the specialist. And if the mother sort of like freaks out and just stops the medication on their own, then it is important that you do review the mother, or if they become they become quickly unwell, to refer them to the emergency department or local mental health team. But if you mention pregnant on clozapine, the mental health team will see the mother very quickly, because clozapine is given and supported by specialists anyway, so they already have a specialist.
Thank you so much, Dr. Seth. Thanks for fitting that last question in.
No problem.
Thank you so much, everyone, for joining us. As I said, that online survey will pop up in your web browser, and keep a lookout for the optional reviewing performance activity that will be emailed to you tomorrow. Thanks so much, everyone.
Thank you so much.